Chapter 11, The Lungs, Part 3. The main function of the lungs is to provide an interface between the alveolar flow, referred to as ventilation, and pulmonary capillary blood flow, known as perfusion. The alveolar surface area is estimated to be at least 75 meters in a young adult, and it does decline with age. The oxygen diffuses across the thin alveolar capillary interface relatively easy, down its partial pressure gradient from alveolar air to capillary blood plasma. At the same time, carbon dioxide will diffuse in the opposite direction. Oxygen delivery within the body is accomplished by binding to the oxygen-carrying protein hemoglobin. The majority of the carbon dioxide travels in the blood in the form of bicarbonate ions, or HCO3. The blood entering the alveolar capillary has an average oxygen of 40 millimeters of mercury, or corresponding to 75% saturation of hemoglobin with oxygen. Immediately on encountering the alveolar partial pressure of oxygen of 100 millimeters of mercury, the oxygen moves down its partial pressure gradient to equilibrate with capillary blood. The oxygen molecules then enter the red blood cells and contribute the final oxygen addition to achieve the 100% saturation. On each hemoglobin molecule, all 4 oxygen binding sites are occupied. Hemoglobin is the necessary protein for oxygen transport. It is a binding site for the oxygen molecule. When oxygen binds to hemoglobin, it depends on the partial pressure of oxygen in the system. The average mixed venous oxygen is 40 millimeters of mercury, which corresponds to 75% saturation of hemoglobin with oxygen. This is the usual composition of blood entering the alveolar capillaries. The average alveolar gas oxygenation is 100% millimeters of mercury. So the loading of oxygen onto hemoglobin occurs up to the routine arterial level of 97.5% hemoglobin saturation, with the partial pressure of oxygen averaging 100 millimeters of mercury. Systemic and local factors can alter hemoglobin's affinity for oxygen and shift the curve to the left, which is greater affinity, or to the right, which is decreased affinity. For optimal gas exchange to occur, it depends on both the rate of ventilation reaching the alveoli and the rate of blood flow, or perfusion, traveling through the alveolar capillaries. At the level of the alveoli, the approximate partial pressure of oxygen is 100 millimeters of mercury, and carbon dioxide is 40 millimeters of mercury. An imbalance between ventilation and perfusion of the alveoli, known as ventilation-perfusion mismatch, is the most common cause of hypoxemia in chronic lung disease. When mixed with oxygenated blood coming from areas with a higher ventilation-perfusion ratio, the partially oxygenated blood decreases the final oxygen saturation of blood leaving the lungs. Hypoxemia caused by the VQ mismatch is typically responsive to oxygen therapy. The air entering the alveoli from the atmosphere continually replenishes the alveolar oxygenation and removes the carbon dioxide. Blood flowing through alveolar capillaries initially has essentially the same composition of oxygen and carbon dioxide as mixed systemic venous blood, but it does equilibrates with alveolar air. Alveolar gas exchange results in the average blood gas composition shown, leaving the alveolar region to join the pulmonary veins, with the oxygen saturation at 100 and the carbon dioxide at 40. If ventilation increases in rate or depth while perfusion stays the same, the oxygen will rise and the carbon dioxide will fall, with a corresponding change in blood gases leaving the lungs. If the ventilation decreases in rate or depth while perfusion stays the same, the oxygenation will fall and the carbon dioxide will rise. If both the ventilation and the perfusion change simultaneously and in the same direction, there will be very little effect on the alveolar and the arterial blood gas levels. Hypoxia is any deficiency of oxygen. Hypoxemia is a below normal level of oxygen in the arterial blood. The hypoxia of tissues can result from low inspired oxygen, as in an airplane or a high altitude, with anemia or a lack of blood oxygen carrying capacity, a lack of perfusion, as in a thromboembolic occlusion, or poisoning that can prevent the cells from using oxygen. Hypoxemia can indicate failure of the lungs to provide adequate gas exchange to sustain life. Alveolar hypoventilation is a state where the breathing depth, rate, or both are very inadequate to meet the body's needs. Generalized hypoventilation due to a neurological or a neuromuscular disorder is a category separate from hypoventilation in the lung disease. The conducting airways of the lungs have no alveoli, and they are unable to conduct gas exchange. Therefore, they are known as dead space. Chronic hypoventilation is often seen in obesity-related hypoventilation syndrome, restrictive thoracic disorders and rib injuries, degenerative neurologic and neuromuscular disorders like ALS and myasthenia gravis, and central sleep apnea. Symptoms for this can include daytime somnolence, fatigue, poor quality of sleep, and snoring. The airway on the left is partially blocked, providing a region of low ventilation, where adjacent regions have normal ventilation. Blood flowing through the underventilated region is unable to pick up sufficient oxygen or remove sufficient carbon dioxide. When mixed with blood perfusing units with better VQ matching, the resulting pulmonary venous blood has lower oxygen and higher carbon dioxide than normal. Oxygen administration can improve oxygenation in ventilation perfusion or VQ mismatch with regional hypoventilation. Increasing the fraction of inspired oxygen generally improves hypoxemia in patients with a VQ mismatch. The effects on the carbon dioxide levels will vary with the degree of regional hypoventilation, but the carbon dioxide and pH levels may remain relatively normal due to stimulation of the respiratory rate and depth by the carbon dioxide sensitive central chemoreceptors. In shunt, one region of the lung is receiving no airflow at all due to atelectasis, mucus plugging, or flooding because of pneumonia or pulmonary edema. Blood flowing through these lung regions has no additional oxygen or removal of carbon dioxide, and this will create more severe hypoxemia and hypercapnia of the mixed pulmonary venous blood. Oxygen administration is not effective at improving blood gases because the inspired air cannot reach the affected regions. Based on Fick's law of diffusion, gas movement down a concentration gradient is dependent on the properties of the gas, the surface area, and the thickness of the barrier to movement, as well as the magnitude of the concentration gradient. Diffusion limitation has several potential mechanisms and causes. It can be due to decreased surface area, alveolar loss like in emphysema, removal of all or part of a lung, atelectasis in which there is complete alveolar collapse, complete alveolar flooding due to edema or inflammatory fluid, thickness of the alveolar capillary interface may increase due to fibroblast accumulation and collagen deposits due to idiopathic pulmonary fibrosis. Fluid accumulation along the alveolar walls in early pulmonary edema or pneumonia. It is more common in individuals with interstitial lung diseases, especially whenever they attempt to increase their physical activity. Diffusion limitation does respond well to supplemental oxygen. Because oxygen therapy will raise the alveolar oxygen concentration, the partial pressure difference across the membrane barrier increases and promotes greater diffusion rate. The pulmonary circulation provides lung perfusion that eliminates carbon dioxide produced by tissue metabolism and provides oxygen for tissue metabolism. The blood vessels of the lungs branch extensively, ending in dense plexus of capillaries that surround each alveolus. Oxygenated blood then returns to the left atrium via the pulmonary veins. Because of the lower pressures, gravity has a sustainable effect on blood flow distribution from the top to the bottom of the lungs, with the smallest amount of blood flow reaching the apex of each lung and the greatest amount of blood flow reach the bases of the lung when seated in an upright position. Lung blood flow is modified by local oxygen saturation. Optimal oxygenation is achieved when the blood flow or perfusion matches ventilation at each level of the lung. Hypoxic vasoconstriction limits the blood flow to poorly ventilated alveoli and maximizes blood flow to well-ventilated alveoli. Pulmonary arterial hypertension, which is an increased pressure in the pulmonary vascular, can damage vessels' integrity, stress the heart, and spill over into negative effects on the systemic circulation that empties into the right side of the heart. As lungs become generally hypoxic, pulmonary vascular resistance rises, creating secondary pulmonary hypertension. Elevated pulmonary artery pressures increase afterload on the right ventricle, which then responds by developing right ventricular hypertrophy and right-sided heart failure. Enlargement of the heart secondary to chronic lung disease with pulmonary hypertension is termed cor pulmonale. Obstructive and restrictive lung diseases commonly associated are COPD, cystic fibrosis, kyphoscoliosis, sarcoidosis, interstitial pulmonary fibrosis, obesity, hypoventilation syndrome, and sleep apnea syndrome. Treatments for the underlying lung condition are beta-2 receptor agonists, inhaled corticosteroids to help reduce inflammation, and diuretics that are directed to decrease the fluid-retaining aspects of heart failure. Pulmonary embolism occurs when a clot or other matter moves from the systemic veins into the pulmonary circulation, causing vascular obstruction. Potential causes of PE can include a thromboembolism, fat, air, amniotic fluid, tumor cells, or septic emboli that are related to bacteremia. Venous thromboembolism is the most common cause. Depending on the size of the clot, the blood flow may be blocked to a lung segment, a whole segment, a lobe, or the whole lung. The greater the degree of vessel occlusion, the more likely it is that the right side of the heart will be unable to pump effectively against the increased vascular resistance, and the left side of the heart will receive inadequate filling, resulting in systemic hypotension. The lung region that is affected by the embolism will receive no perfusion, but will still continue to be ventilated and now constitutes additional dead space. This will lead to hypoxia and tachypnea to try to compensate. Presentation of a PE will include dyspnea, which can be accompanied by chest pain, cough, and hemoptysis. Pulmonary edema is defined as the accumulation of fluid in the alveoli. Acute decompensated heart failure is the most common cause, and additional causes can include volume overload secondary to blood transfusion, severe hypertension, renal artery stenosis, and severe renal disease. Transfusion-associated circulatory overload is a form of volume overload that is related directly to the amount of volume. Acute respiratory distress syndrome, which is caused by damage to the alveolar capillary membrane that greatly increases the permeability, alters normal alveolar osmotic balance, and promotes capillary filtration. The rate of capillary filtration overwhelms the capacity of lung lymphatics to remove the edema fluid. Disease processes that can precipitate ARDS are sepsis, pneumonia, aspiration, trauma, transfusion, pancreatitis, and drug overdose. ARDS produces pulmonary edema due to macrophage and neutrophil recruitment and activation that greatly increase alveolar capillary permeability and damage type 1 and type 2 AECs. The loss of surfactant contributes to the alveolar flooding and atelectasis. Relative to adults, infants and children have significant differences in lung structure and function. Respiratory rate is high at birth. There is reduced elastic recoil, less airway support, and greater tendency to develop airway collapse. The chest wall is more flexible. The chest wall moves inward rather than outward and known as paradoxal movement. Surfactant production does not begin until 25 to 27 weeks. Then the surfactant production increases parallel with alveolar formation. Formation of alveoli begins late at 36 weeks and continues after birth. Surfactant production begins between 25 and 26 weeks, so premature infants may develop neonatal respiratory distress syndrome. Bronchopulmonary dysplasia is associated with the development of abnormally large and simplified alveoli, altered pulmonary capillary development, and some interstitial fibroproliferative changes. RSV is the most common cause of pneumonia and bronchiolitis in infants. Bronchiolitis causes tissues around the bronchioles to be swollen with white blood cells and inflammatory secretions, obstructing the small and delicate airways.